Calculus index, very similar to the debris index. Here's our calculus index, a score of 0 when no calculus is indicated or viewed by the staff member. The gingival 1/3 would receive a score of 1. The coronal 2/3 and some subgingival calculus would be viewed as a 2. 2/3 or greater surface, coronal surface covered with calculus, and more subgingival would then be classified as a 3. The calculus index in the primary dentition, you don't see this very often, but it is there and it should be scored. We're going to look at the facial surfaces of teeth A and F, the facial and lingual surfaces of teeth K and P, the calculus scoring 0 to 4, no calculus gets a score of 0, supragingival 1/3 is a score of 1, 1/3 supra plus subgingival is a score of 2, and greater than 1/3 supra plus subgingival is a score of 3. Add the total, divide by 6. Calculus index for the transitional dentition is recorded by using the facial surfaces of tooth number 3 and the lingual of number 9, the facial and lingual surfaces of tooth numbers 19 and 25. Calculus scoring, similar to the last one, no calculus receives a score of 0. Supragingival 1/3 equals a score of 1. 1/3 supra plus subgingival score is a 2. Greater than 1/3 supra plus subgingival score as a 3. Add the total and divide by 6. Calculus index for permanent dentition, facial surfaces of tooth numbers 3 and 14, lingual surfaces of 9, 19, 25, and 30. Calculus scoring, you can again refer to the manual for more of this information and make it easier. Add the total and divide by 6. Here's a slide depicting calculus, and this would be a calculus of 1. You can see right there at the gingival margin, the lower anterior lingual surfaces, a slight white line, which is indicative of your calculus. Score the calculus as follows. Excellent, good, fair, or poor. There's your scores on the right, and again you can use the paper calculator provided in the manual. The oral hygiene index is simply a total of the debris index plus the calculus index. Ratings are excellent, good, fair, and poor, and the calculator will quickly provide that score for you and your staff members. The DEF, primary dentition, decayed, extracted due to caries, and the filled. The DMF, which is your transitional dentition, is count both the primary and the permanent teeth. Do not count the missing incisors, do not count congenitally missing teeth, and do not count teeth extracted for orthodontic reasons. For adult and permanent teeth, use this format when all teeth 2 to 31 are erupted. Do not count your congenitally missing teeth or teeth extracted for orthodontics. The objective data collected by the doctor. Your doctor's responsibility is once you sit down, we're going to do our clinical exam, we're going to evaluate the subjective data of the patient that was collected by the staff, and we're going to evaluate the objective data recorded by the staff. We're going to establish the DEF, the DMF, or the adult DMF. We determine the periodontal classification, and we're going to use our clinical judgment to prescribe the use of a CRT if we feel that it's needed. The final DEF should be established by the doctors. Staff is certainly going to look at the patient's mouth, and they're going to see how many teeth are filled, but it's your responsibility to make sure that that was done accurately and to add any surfaces or any teeth that you have found that are now decayed or have been missing since the last examination. Here's graphically what the doctor is going to be looking for: perio, the CRT, salivary flow test, the scores of the CRT, and we'll get into the CRT in a lot more detail here in a few slides. We're going to assign a caries risk. You're going to take any photos that you feel that are necessary. Periodontal disease. Localized means that less than 30% of the teeth are affected. So you just call this a localized periodontal disease process. Generalized when greater than 30% of the teeth are affected. Dental disease threatens health. It's becoming more and more important for the dentist to check gingival health because there are problems that can lead to systemic problems, heart problems, if we're not checking periodontal health. Is this patient a cardiovascular risk? Well, today we know that they are, because the same bacteria that are found in the deep pockets in periodontal disease are also found in the heart valves of cardiovascular heart attack victims. It's our responsibility to notify the patient, because of the oral condition and periodontal disease, that they should also see their cardiac physician. Classification of periodontal disease: type 1 gingivitis, no clinical loss of attachment, signs of inflammation, bleeding, swelling, and redness. Type 2 periodontal disease, slight early or mild periodontitis, 1 to 2 millimeters of clinical attachment loss, pocket depths to 3 to 4 millimeters. Type 3 moderate periodontitis, 3 to 4 millimeters of clinical attachment loss, pocket depths 4 to 5. Type 4 advanced periodontitis, greater than 5 millimeters of clinical attachment loss, 1/3 bone loss, and pockets 6 millimeters or greater. The decision-making flowchart that we use in our office at first glance seems rather quite complicated. This is one that we established to determine whether or not we should be taking caries risk tests. If we're going to take them, who we should take them on. Initially, if we took caries risk tests on nearly every patient to make sure that we weren't missing something that we could see clinically, and to find out if our tracking sheet was going to provide the accurate information that we needed. Basically, a new patient can come in and we decide to take a caries risk test. What we're looking at during the caries risk test is the bacterial growth of the strep mutans bacteria and the lactobacillus. You can see here that if to the left, if the mutans, strep, and the lactobacillus are greater than 100,000 colony-forming units, that the patient will end up classified as a level 3 or a level 4. If those strep counts are less than 100,000 colony-forming units, the patient will be classified as a level 1 or level 2, unless there are other factors that you see clinically that you might want to bump that risk factor up. The tracking exam gets to the same point. If you take your subjective and objective data, you can immediately classify these patients in level 1 or level 2, level 3 or level 4, depending on your experience and your ability to be a detective. If you know you've got a high plaque, high calculus counts, gingival bleeding, then you know that patient is probably going to be classified as a level 3, level 4. With lower levels of those items, less gingival bleeding, less plaque, less calculus, you can classify that patient as a level 1, level 2.